Open appendectomy procedure under spinal anesthesia in supine position, oblique muscle splitting incision kept. The cecum is grasped from the tinea and delivered from the wound, allowing visualization of base of the appendix and delivery of the appendicular tip. The mesoappendix is clamped, cut, and ligated. The appendix transfixed and ligated at the base. Drain kept when necessary and the wound closed in layers. Next slide. Laparoscopic appendicectomy. Under general anesthesia in supine position, pneumoperitoneum created. Abdomen is entered at the umbilicus by camera port, and two additional working ports are placed in left lower quadrant and suprapubic area. Atraumatic grasper are used to elevate the appendix and mesoappendix carefully divided using monopolar cautery. The base is then secured with endoloop and appendix divided. Appendix retrieved in back, pelvis irrigated and drain kept when necessary. Trocars removed and closure done. Next slide. Post-operative period. Most of the patient received antibiotic for 3 to 5 days. Drain removed on second or third post-op day unless required. During the post-operative period, the patient were examined for vitals, condition of wound, abdominal distension, and other specific complaints. Next. Observation and result. Table 1. Time for operation. Time taken for 8 patients for laparoscopic procedure was around 60 to 80 minutes, and for open procedure for 16 patients it was 40 to 60 minutes. Next slide. In our study, mean operating time being 65 minutes for laparoscopic appendicectomy and 50 minutes for open procedure, with a mean time difference of 15 minutes between two procedures. Next slide. Post-operative complication. We included complication after appendicectomy, a fever, wound infection, paralytic, yes, intra-abdominal abscess, fecal fistula. Next slide. 4 out of 18 patients of laparoscopic appendicectomy, where 8 out of 30 patients after open procedure developed post-operative complication. Wound infection was commonest among them. Laparoscopy has a lower incidence of complication than open procedure. Next slide. Resumption of diet. Next slide. Mean time for resumption of diet for laparoscopic procedure was 43 hours, and open procedure it was 54 hours, with mean time difference of 11 hours. Shows there is early resumption of diet in laparoscopic procedure. Next slide.
2 minutes left.
Hospital stay. For most of the patient in laparoscopic procedure, the hospital stay was around 4 to 5 days, and for open procedure it was 5 to 6 days. Next slide. Mean post-operative hospital stay in laparoscopic procedure was 3.4 days, and open procedure was 4.8 days. Patient with post-operative complication were kept hospitalized for more time than usual. Next slide. Return to normal activity. Next slide. Mean number of days for return to normal activity was 11 days in laparoscopic procedure, and open procedure it was 12 days. Next slide. Conclusion. Laparoscopic appendicectomy is better compared to open in relation to postoperative complication, resumption of diet, hospital stay, and return to normal activity. It also allows examination of whole peritoneal cavity to exclude other pathology and technically simple in obese patient. Disadvantage include longer operative time and conversion to open. However, clearly superior choice has not been conclusively demonstrated, but laparoscopic approach is safe, simple, and efficient in experience. And most important aspect of appendicectomy is that it should be done promptly and safely. Thank you.
Okay, Dr. Akshar.
Yes, sir.
What was your complication rate in open appendicectomy?
Sorry, sir.
Your wound infection rate in open appendicectomy.
Sir, wound infection rate was, sir, in sir around.
You can refer your slides if you want.
Yes, sir. In open procedure, it was sir 10%, sir, and in laparoscopic procedure, it was 5%, sir.
So all your appendicectomies were planned surgery. So how do you explain 10% of wound infection in planned surgery?
No, sir. It was, sir, emergency procedure, sir. All were cases in acute appendix, sir. All patients were operated uh, in emergency, sir, as a case of acute appendicitis, sir.
So this you have not mentioned in your study then, that whether the how many surgeries were planned surgeries, how many surgeries were emergency surgeries.
Uh, no, sir.
Nowhere.
All were as a acute appendicitis. We operated all patient in emergency condition, but some patient we operated as a laparoscopy, and some patient in as a open procedure, sir.
So all 50 patients were in emergency surgery.
Yes, sir.
Okay, thank you.
Yes, sir. Thank you, sir.
Thank you, Dr. Akshar Patel. Next is Dr. Akib Patel.
Good afternoon. Here is my presentation of factors that is predicting conversion of laparoscopic to open cholecystectomy. Am I audible?
Yes.
Yeah. I'm Dr. Akib Patel. I'm third year resident in BJ Medical College under the guidance of Dr. Parth Hardala and Dr. Jayesh V. Pari. Next slide, please. The study was planned to identify the factors that can predict or for conversion of laparoscopic to open cholecystectomy. The aim and objective of the study is to identify patients that were higher risk of conversion, so that we can better preoperative counsel the patient and for a better post-operative preparation for the patient. Laparoscopic cholecystectomy is preferred by surgeons and patients because it has advantages of shorter hospital stay and less post-operative pain and better osmosis. Conversion rate of 2.6 to 14% has been described in the previous literatures. Conversion from laparoscopic cholecystectomy to open cholecystectomy results in a significant change in the outcome for the patient because of the higher rate of post-operative complications and the longer hospital stay. Conversion to open cholecystectomy is occasionally necessary to avoid or repair the injury or to delineate any confusing anatomic relationships that happens with the cystic artery or with the double CBD or with an abnormally inserted CBD or a cystic duct. Next slide. The study was conducted in the Department of General Surgery, and the cases were included between January 2009 to January 2020. That's a period of 1 year. And a total of 50 patients were included in the study, amongst which 10 were converted to open cholecystectomy. Factors recorded and analyzed were age, sex, duration of pain, past history of abdominal surgery, presence of diabetes mellitus, total leukocyte count, USC finding of number of stones, stone size, GB wall thickness, and pericholecystic fluid, preoperative ERCP, and gallbladder adhesions. Next slide, please. All patients admitted underwent preoperative blood testing, ultrasound of biliary tract, routine preoperative investigations, and additional investigation as and when required. Laparoscopic cholecystectomy was performed using standard 4-port technique with the pneumoperitoneum using Veris or Hassan technique for carbon dioxide insufflation. Statistical analysis was done using independent t-test and chi-square test. Next, please. Amongst the results, amongst the 50 patients, 10 were converted to open cholecystectomy. Next, please. There are various tables which shows the parameters amongst which age, gender. Next, please. Age and gender was the significant, and duration of pain, past history of any abdominal surgery was not significant. Duration of pain shows whether it is acute or a chronic condition. Past history of abdominal surgery shows whether there may be intraoperative adhesions may be present. In diabetes mellitus, more of a diabetes, more of a condition with uh, more of infection that is leads to increased conversion rate. Total leukocyte count, increased leukocyte count gives a indication for more of infection, which causes more of a conversion rate that was found significant. Next, please. The number of stones, whether single or multiple, was not found significant for conversion to open cholecystectomy. Stone size arbitrarily was taken between less than 7 to greater than 7 mm, which was not significant. GB wall thickness, more of a thickness, the normal is less than 3 millimeters. If at all it is greater than that, it's considered thickened. thickened GB wall was considered significant for conversion to open cholecystectomy. If at all there was a pericholecystic fluid, it suggests more of an inflammation localized, which causes more of a conversion to open cholecystectomy. Next, please. Preoperatively, if at all ERCP is performed, it gives more rise to inflammation locally, which is not significant in our study for conversion to open cholecystectomy. Gallbladder adhesions was considered a significant parameter for conversion to open cholecystectomy, and even cholecystitis was not found as a significant parameter for conversion to open cholecystectomy. Next. Gallstones are the most common biliary pathology, and laparoscopic cholecystectomy has been considered as a better operative procedure because of multiple advantages. That is, a less hospital stay, being the patient convenient, better cosmesis, and it's considered as a gold standard procedure. Look, previously 2.6 to 4%, 14% of conversion rate has been found. Conversion from laparoscopic to open procedure should not be visualized as a complication, but rather it should be considered as a reflection of a sound surgical judgment in a difficult cases. Next, please. Review of literature. In the meta-analytical study carried out by Rothman, the following parameters were found to be significant. That was GB wall thickness of 4.5 mm, contracted GB or age or male gender, acute cholecystitis, diabetes mellitus, body temperature, and leukocyte count. A high leukocyte count was not found to be significant for conversion. Our study was comparable in terms of age, gender, and GB wall thickness, but found a significant correlation with the presence of comorbidities such as diabetes, and investigations such as elevated WBCs. In a prospective study carried out by Shandio, found that choledocholithiasis and acute cholecystitis were independent factors that resulted in conversion to open cholecystectomy. They further added that GB wall thickness is a radiological marker, inflammation, and hence not an independent variable in conversion of open cholecystectomy. Our study did not find acute cholecystitis a significant risk factor in conversion, even when the Shandio reported a tenfold increase in the conversion with histological acute cholecystitis. Next, please. Mukherjee in the study found that previous abdominal surgery was not a significant cause for conversion, and this was consistent with our study as well. However, the presence of adhesions as a result of previous interventions was found to be one of the most common causes increasing conversion rate, which was true for our study as well. Other factors that resulted in conversion were CVD injury or any instrument failure or bleeding or malignancy. In study carried out by Thiagarajan, factors such as increasing age, male gender, diabetes mellitus, previous acute cholecystitis, or GB wall thickness more than 4 mm, pericholecystic fluid were all significant factors in conversion to open procedures. Next, please.
2 minutes left.
A risk score for prediction of conversion of laparoscopic cholecystectomy has previously been created, but the question is if the score uses the relevant preoperative variables to predict conversion. Previous upper abdominal surgery weighs heavily in their risk score. Identification of these risk factors make it possible to identify high-risk patients and thereby make relevant planning or logistic adjustments. Next, please. This could be done only by having surgeons experienced both laparoscopic and open. Moreover, by performing daytime only surgery, more experienced surgeons may be available for consultation in case of difficulties. Another advantage is the possibility of informing the patients preoperatively for risk for complication, longer hospital stay, and to aid in for the selection of patient not suited for the conventional surgery. Planning for interventions such as subtotal cholecystectomy can be preoperatively explained to the patients. Next, please. Limitation of the study is that multiple surgeons, along with their experience, shows the variable in dealing with the patients with particular pathology. Next, please. So we can conclude that age, male gender, diabetes, increased WBC count, and increased GB wall thickness with presence of pericholecystic fluid and GB wall adhesions are the risk factors for conversion of laparoscopic to open cholecystectomy. None of them were the contraindications, but this gives a better prediction for conversion to open cholecystectomy. Next, please. These are the references. Thank you very much.
Okay, Dr. Akib.
Yes, sir.
How would you identify surgical anatomy preoperatively? Surgical anatomy of vascular structures. Do you think it may, if you identify a proper vascular anatomy, as you know, there are different variations of the vascularity and the structures in the Keller's triangles. So
Sir, it cannot be Yes, sir. Maybe by cannot be identified sir pre-operatively, or we can go for a CT angio. But sir, it's cumbersome for the patient, and we expose the patient to a very high amount of radiation, sir.
Okay, thank you.
Okay, thank you.
Thank you, Dr. Akib. Next is Dr. Ashwin Modi. Dr. Ashwin Modi.
Good afternoon, everyone. Myself, Dr. Ashwin Modi, third year resident, Radiology, NHL Medical College, and I am presenting a paper on role of imaging in hydrated cysts from head to toe. Next.
Okay.
My aims and objectives are describe the imaging features of hydrated disease in various anatomic locations, discuss the role of ultrasound, CT, and MR imaging in the diagnosis of hydrated disease. Next. Introduction. In hydrated disease is a parasitic disease that is endemic in many parts of the world. Hydrated disease may occur anywhere in the body and demonstrate variety of imaging features that will vary according to the growth stage and associated complication and affected tissue. The radiological findings range from purely cystic lesions to a completely solid appearance. There are two types of Echinococcus infection. Echinococcus granulosis is a more common type, whereas multilocularis is less common but more invasive, mimicking a malignancy. Pathophysiology of the hydrated disease are the main includes dogs or other carnivores are definitive hosts. Sheep or other ruminants are the intermediate host. Humans are secondarily infected by the ingestion of the food or water that has been contaminated by the dog feces containing eggs of the parasite. After the outer capsule of the egg has been ingested, freed embryo enters the branch of the portal vein by passing through a duodenal mucosa. Most of these embryos become lodged in the hepatic capillaries, where they either die or grow into hydrated cysts. Some pass through the capillaries and become lodged into lung and other organs. Next, life cycle of this is the chart showing the life cycle of granulosis, how it is acquired in the human body. Next, clinical presentation includes hydrated disease patient can remain asymptomatic for many years, and its clinical manifestation depends on the anatomical site involved, the size of the cyst, and or any other complications such as bacterial infection or cyst rupture. Clinically, anaphylactic shocks has been described as the most serious associated complication, particularly in the setting of the cyst rupture. Next. Hydrated cysts are classified into four types on basis of their appearance. Type 1 is a simple cyst with no internal architecture. These appear as a well-defined anechoic mass with or without hydrated sand or septa. Unilocular cysts are considered to be an initial stage in the development of the parasite tooling. The patient during evolution disperses the sand by creating a small echogenic foci or falling snowflakes. At CT, type 1 hydrated cysts appear as a well-defined water attenuation mass. MR imaging features are also similar to those of a simple liver cyst and include hypointensity on T1 and marked hyperintensity on T2 weighted images. A low signal intensity rim or rim cell, which is more evident on T2 weighted MR images. Next. Type 2 includes cyst with the daughter cyst and matrix. Daughter cysts are seen inside the mother cyst. Floating membranes and vesicles can also be seen in the cyst. Sometimes the multilocular cyst and echogenic areas are enclosed together with a single capsule, give rise to a Rasmus or spoke wheel appearance. At CT, type 2 hydrated cyst can be visualized in three stages depending on the age, number, and the arrangement of the daughter cyst. Type 2A lesions containing round daughter cyst arranged at the periphery. The average CT attenuation of the mother cyst is higher than that of a daughter cyst. Type 2B lesions are containing large irregular shaped daughter cyst that occupy almost the entire volume of the mother cyst. The high attenuation of the fluid that surrounds the daughter cyst within the mother cyst look like a septa, creating a rosette appearance. Type 2 cyst lesions appear at CT related to attenuation around or over with scattered calcification and daughter cyst. This finding represents the degeneration of the old cyst with amorphous and tenacious contents. At MR imaging, daughter cyst may appear as hypo or isointense relative to the maternal matrix on T1 and T2 weighted images. The serpent sign or snake sign, which represents the collapsed parasitic membrane secondary to damage or degeneration of the hydrated cyst, is another MR imaging manifestation of a hydrated cyst. These membranes have a low signal intensity with all sequence. Next. Type 3 includes calcified cyst. Type 3 lesions are the dead cyst involving total calcification. They demonstrate posterior shadowing on ultrasound. Hypernatrinating areas are at CT and hypointense area at MR imaging. Type 4 includes complicated hydatid cyst. Hydatid cyst complication include rupture and superinfection and are seen in both type 1 and 2 hydatid cyst. Rupture can occur in 50 to 90% of cases. Cyst rupture mainly due to degeneration of the parasitic membranes as a result of age, chemical reaction, or host defense mechanism. Hydatid cyst rupture may be contained, communicating, or direct. In contained rupture, the undulating membrane resulting from the separation of the endocyst from the pericyst is seen at both ultrasound and CT and manifest as a postural changes. A snowstorm pattern has been described at ultrasound. The infected hydatid cyst may exhibit mixed echogenicity. At T2-weighted MR images, the membranes appear as a hypointense linear regions. Communicating rupture appears more echogenic than contained rupture. At ultrasound, layering of the hydatid sand can be seen in the biliary channels in cases of intrabiliary rupture. Bacterial superinfection of the hydatid cyst is always secondary to rupture. Rupture cyst may become infected. Signs of cyst infection include poor delimitation, mixed inter-echos, fluid or fluid levels. These signs are also seen in both intact hydatid cyst and ruptured and uninfected hydatid cyst. The presence of air within the cyst establishes the diagnosis of the direct or communicating rupture, but does not necessarily imply infection. Next. Imaging in the hydatid disease, a chest film or other plain films can be the first diagnostic modality when the hydatid disease is suspected in the lung. Imaging, depending on the clinical indications, ultrasound is the primary imaging modality usually to diagnose and evaluate hydatid disease in the liver, and in some cases it may be only imaging modality needed. In extrahepatic locations, you include the spleen, kidneys, pelvis, pleura, and heart. CT and MR imaging have important roles in evaluation of the extrahepatic hydatid disease, as they enable better assessment of the extent of the larger lesions and the relationship of the cyst with surrounding structures. CT enables one to better define cyst calcification. This is crucial for determining lesion viability. MR imaging often offers excellent contrast resolution and thus enables exquisite definition of the internal cyst contents. Next.
2 minutes left.
Discussion this includes the WHO classification of the cystic echinococcosis. There are 5 types of the basic ultrasound appearance. There's 1, 2, 3, 4, 5, and 1 and 2 are the active, and 4 and 3 are the inactive. Our 3 is a transitional phase. Next. This is the detailed classification of the hereditary disease. Next. Next. This is the case one, a 30-year-old female patient can be the complaint of the pain in abdomen. This shows the liver cyst. On USG, liver and spleen shows the multiple cystic lesions scattered throughout the liver and spleen. The lesions show no obvious vascularity within. Next. On CT, abdomen and pelvis imaging, on CT imaging, multiple thin wall, multilocular variable size cystic lesions are noted in liver and spleen. The lesions show peripheral rim of enhancement. On MRI, multiple thin wall variable size T2 hyperintense cystic lesions are noted in liver and spleen. Next. This is the case 2 patient came with a complaint of a headache. On CT brain imaging, a well-defined cystic lesion with wall calcification is noted in the right parietal region. Next. This is case 3 patient with left hypochondriac pain. On CT imaging, a well-defined thin wall cystic lesion is noted in the spleen. The lesion shows wall calcification. Next. Patient 4, this is case 4. Patient came with a complaint with lower abdominal pain. On USG, multiple thin wall variable size cystic lesions are noted in the retroperitoneum region. The lesion shows peripheral rim of enhancement. And on CT imaging, multiple thin wall multilocular variable size cystic lesions are noted in retroperitoneum region. The lesions show peripheral. Next. On MR imaging, the multiple thin wall T2 heterogeneous hypercystic lesions are noted in retroperitoneum. Next.
Time's up. Please wrap up, sir.
Okay, next, conclude. Next, hydatid disease can affect virtually any organ system in body. Commonly, it demonstrates characteristic imaging finding differentiating hydatid disease from the other entities. However, at times it presents with atypical imaging findings due to atypical sites or secondary complication. Knowledge of these uncommon imaging features is ensuring correct diagnosis and prompt treatment, thereby reducing patient morbidity.
Okay. Suppose there is a hydatid in liver. How early can it be detected radiologically in USG based?
How early?
What size? What the what list size can be picked up?
So any cyst, at least 1 centimeter size cyst can be detected by USG. Our characterization requires more size, around 3 to 4 centimeters.
Okay, 3 to 4 centimeters. Okay, thank you.
Okay, thank you.
Next is Dr. Bansil Javia. Dr. Bansil? Okay, we will continue with the next, that is Dr. Bhargav Vasyani.
Hello.
Hello.
Yes, I am Dr. Bhargav Vasyani, second year surgery resident in NHL Medical College. My topic for presentation is liver abscess drainage by needle aspiration versus pigtail catheter under guidance of Dr. Kirit Parmar, Dr. Pratik Vyas, and Dr. Varun Bajaj. Next slide. Liver abscess is defined as a pus-filled mass in the liver that can develop from injury to the liver or intra-abdominal infection disseminated from the portal circulation. It is a disease of frequent occurrence which figures prominently in the differential diagnosis of upper abdominal and right lower respiratory tract disease. This includes a recent increase in incidence reflecting more accurate diagnostic technique, especially after 1965 with the advent of radioisotope scan and later on ultrasonography and CT scan. The reduction in mortality from 90% at the turn of century to estimated 10 to 20% today cannot be ascribed to surgery alone. Next slide. The study was conducted on 50% of liver abscess. Two compared modalities of percutaneous treatment of liver abscess were needle aspiration and pigtail catheter aspiration. All interventions were performed under ultrasonographic guidance with adequate and proper equipment and with post-procedure emergency care if required. Only those patients having liver abscess greater than 5 cm in at least one dimension, liquefied and drainable were included in this study. Next. Liver abscess is a disease of frequent occurrence which figures prominently in the differential diagnosis of upper abdominal right lower respiratory tract disease. Even with the advent of good diagnostic investigation like USG, the diagnosis is still delayed because of the non-specific manifestation of disease, and therefore the suspicion of diagnosis is important. The traditional therapy of intra-abdominal liver abscess has been operative drainage, as originally described by Walkman in 1879. The reduction in mortality from 90% to the 20% cannot be ascribed to surgery alone. Rather, the sophistication of new radiological techniques like CT scan ultrasonography has not only prescribed tools for accurate localization of the abscess, but it has also created the possibility of their safe aspiration and drainage in certain instances, awaiting the need for surgical intervention. Next. Currently, there are two alternative methods for drainage of pus from large liver abscess. Percutaneous therapeutic procedure have been increasing performed compared with open surgical drainage. This study aims to compare the therapeutic effectiveness and safety of percutaneous continuous catheter drainage versus percutaneous intermittent needle aspiration. Modern treatment has been shifted the treatment of liver abscess towards the large spectrum antibiotic and imaging guided percutaneous needle aspiration or percutaneous catheter drainage. Next. Here the patient inclusion criteria. This study includes all the patients coming to the SVP hospital surgery OPD with the diagnosis of liver abscess of size greater than 5 cm by ultrasonography from a period of May 2019 to September 2020. Abscess that were amenable to only surgical drainage like rupture or concomitant surgical pathology required urgent surgical exploration were excluded from the study according to our criteria. Material used is ultrasonography machine, aspirin needle, mostly 18 gauge disposable needle. Next. Pigtail catheter set with trocar, dilator, and guide wire. Trolley setting in which 50 ml syringe, sterile gloves, kidney tray, scalpel bed, and the local anesthetic like lignocaine and sterile pads and gauze piece. Next. In all the cases, the abscess were located by USG. The patient were subjected to routine hematological investigation. Chest X-ray were done to not any pulmonary complication in terms of position of diaphragm and any effusion in pleural cavity. Only those patients in whom the abscess were liquefied were taken for aspiration, while the other where abscess was unliquefied, even liquefied, but single size less than 5 cm. Only antibiotics were given. Next. Pre-aspiration procedure, written consent of the patient, baseline investigation, routine investigation, and pre-medicine like vitamin K injection and atrodiclo injection. Next. techniques. For needle aspiration, depending upon the abscess to be drained, the patient was given appropriate position. The appropriate part of abdomen and lower chest was cleaned, thoroughly skinned. Abscess cavity was located, and appropriate route decided to avoid important structures. The shortest path that caused minimal liver parenchymal trauma was chosen. Depth of abscess from skin, appropriate angle of the approach, and exact site of puncture was determined. Next. Next, please. Local anesthesia was given. A patient was asked to hold his breath, and the 18 gauge needle was passed over the abscess cavity with the predetermined angle and up to the predetermined depth. Presence of needle in the abscess cavity was confirmed by giving a waste sensation, scanning needle tip echo, and the free flow of pus. Syringe was applied to the 18 gauge needle, and pus was aspirated and sent for the culture. Intermittent needle aspiration will be done with 18 gauge disposable needle. Aspiration will be repeated if there is either no clinical improvement or no reduction in size of the abscess cavity. Aspiration done up to maximum of 3 times. Next, please. It's about the pictal catheter drainage. Same procedure were done until the local lens is given. Thereafter, trocal of pictal cells was slowly inserted until it reached the abscess cavity. Then a guide wire was passed through it. Then over guide wire, trocar was removed. With the help of dilators, the tract was dilated by serially passing the dilator over the guide wire, and then pictal catheter drain was kept in abscess cavity. The draining catheter was properly secured in its place and connected to a collecting system. At the point first USG is done for residual cavity, and the catheter is left in situ. From this point, USG is done very third day until abscess cavity disappears, decreases in size, and remains static compared with the previous USG, and catheter is removed if there was no draining for the last 24 hours. Next, please. Next. In post-operative precaution, we have watched for the signs of peritonitis, regular temperature charting, blood pressure charting, systemic antibiotic given, and SOS analgesic was given. Next, please.
2 minutes left.
In all our patient, there was IV antibiotic like ceftriaxone, metronidazole was given. As soon as the culture arrived, we had started the antibiotic according to culture. Next, please. The criteria of successful percutaneous intervention will be taken as adequate drainage of abscess to allow resolution of infection without the need for surgical drainage, and subsequent discharge of patient from the hospital. Patient outcomes will be recorded on the basis of duration to attain clinical relief, duration of hospital stay, treatment success and failure rates, and death. Criteria for discharge of the patient will be discharged from the hospital when the infection had subsided clinically. Sonographic evidence of abscess resolution, such as disappearance of abscess cavity or static or decrease in the size of abscess cavity. Next, please. The study was conducted on 50% of liver abscess. Out of 50%, the 3 were excluded because of pre-treatment of rupture of abscess and 1 because of negative consent. Remaining 46% were divided into 2 groups, 23% for needle aspiration and 23% for pictal catheter group. There was no statistically significant difference found in the patient characteristics like age, sex, religion, comorbidities. Between 2 groups, it was observed that, next please. Commonest age group for the occurrence of liver abscess was between 21 to 40 years. Liver abscess occurrence more commonly in male than in females. Commonly comorbidity was in our group was gallbladder or common bile duct calculi. Common symptom in both group was fever. Solitary abscess were more common than multiple abscess. Right lobe abscesses were more common than the left lobe abscess. Amoebic liver abscess were more common than the pyogenic liver abscess. And volume of pus drained in the first setting by catheter group was significantly more than the needle aspiration group. Clinically, recovery was significant earlier in catheter group than in the needle aspiration group. Duration of hospital stay is significantly shorter in catheter group than in the needle aspiration group. Next, please. Liver abscess is a very common clinical problem in India. The most common cause of liver abscess in India is the amoebic liver abscess. The comorbidities include the gallbladder, common bile duct calculi, cholecystitis, diabetes mellitus, cholangitis, or appendicitis. Next, please.
Time's up. Please wrap up.
Okay, can you go to the conclusion, please? Thus, our study concluded that in view of greater volume of pus drain in the first setting, early clinical recovery, shorter duration of hospital stays, and slightly more success rate in continuous catheter drain is effective percutaneous treatment modality than the intermittent needle aspiration group. Although because of small number of patients studied in shorter duration and a human error is always possible, result may vary in different studies. Thank you.
Okay, Dr. Bhargav, what is the role of multiple aspirations over the pigtail? Multiple
Sir,
aspirations.
sir, in case of large abscess where in first sitting there is no greater volume of pus drained, then if we give antibiotic for some more days, then the abscess will be more liquefied and approachable and aspirable. Then we can again aspirate the abscess. And sir, in pigtail catheter, we cannot reposit the catheter. We have to reapply the whole pigtail again, sir.
Okay, thank you.
Okay, sir. Thank you, sir.
Thank you, Dr. Bhargav. Next, we have Dr. Dharmik Gondalia.
Hello, am I audible?
Yes.
Actually, I am presenting from Dr. Jaydeep's account. I am facing some technical issue, that's why.
Okay, no issues.
Okay, good afternoon, sir. Myself, Dr. Dharmik Gondalia. I am presenting my paper on to study the clinical outcome of the emergency surgeries in confirmed cases of COVID-19 under the guidance of Dr. Kirit D. Parmar, sir, Dr. Pratik H. Vyas, sir, and Dr. Varun B. Bajaj, sir. Next slide, please. Next slide. Introduction: an incomparable outbreak of the previous slide one, the introduction slide.
Next slide introduction. Previous slide introduction.
Okay. An incomparable outbreak of the respiratory illness in Wuhan, Hubei province, China, was declared in December.
Vasectomies were performed in our hospital from April 2018 to February 2020, which includes 35 open surgeries and 257 laparoscopic surgeries. From this total 292 cases, 10 cases of biliary leak were studied. In the present study of 10 cases, fundus first method was done in open surgeries only. That was 3 cases, whereas classical procedure was done in 7 cases, out of which 5 cases were done in laparoscopic method, whereas 2 cases in open method. Intraoperative detection of bile duct injury was noted in 3 cases of open cholecystectomy and none in laparoscopic method. Next slide, please. So now in discussion, the most common and post-operative symptoms for biliary leak remain same, and the most common and earliest symptom is pain in abdomen, that is 24%, followed by jaundice, vomiting, fever. Patient may also have ileus, cholangitis, and peritonitis. Next slide, please. For post-operative diagnosis, chronic cholecystitis remain the incidence of chronic cholecystitis remains the higher in cases of biliary leakage. Acute cholecystitis, cholelithiasis, empyema or pyocele, and mucocele of gallbladder are also there. Next slide, please. Now, comparing the operation, that is laparoscopic or open surgery, the incidence of bile duct injury was almost same in open and compared to laparoscopic surgeries. The number of bleed percentage were higher in open surgeries, whereas low in laparoscopic surgeries. Next slide, please. For abdominal collection, cases in which tube drain have been kept to detect the postoperative bile leak have resulted in controlled fistula with almost no signs of localized or generalized peritonitis. In uncontrolled fistula, huge volume of bile accumulate in the peritoneal cavity, or sometimes in subphrenic or subhepatic spaces. Subdiaphragmatic collection are seen only in 16% of cases on postoperative sonography of abdomen, and generalized peritoneal collection seen in 1 case, that is 4%, due to blockage of drain. No collection is seen in about 80% of cases because of free flow of bile through the drains. Next slide, please. In 7 cases, drains were removed by 6 post-op day, in which the injury was detected in 1 cases. In 5 cases, drains were removed after 14 post-op day, in which the injury was found in 3 cases. Now talk about the mortality and morbidity. The mortality and morbidity remains the higher side in cases of open surgery, that is 0.5% of mortality and 5% of morbidity, whereas laparoscopic procedure found to have less mortality, that there is 0% mortality and 2.7% morbidity. Next slide, please. Now we talk about the management part. For biliary leakage, post-operative biliary leakage, the management will be considered as conservative. 56% patient has been conservatively managed post-operatively, followed by endoscopic stenting, sphincterotomy plus stenting, or intraoperative primary repair with T-tube insertion, and 1 case has been re-explored for biliary leakage. Next slide, please. So in my conclusion, pain in abdomen, jaundice, nausea, and vomiting are the major complaints in the case of bile leaks and fistulas. Pathologically, chronic cholecystitis is commonest cause of leak after surgery, mainly because of fibrosis at callus triangle. Incidence of postoperative bile leak is almost the same in open and laparoscopic cholecystectomy. Routine placement of drains is must because it permits postoperative evacuation of serosanguous exudates and monitoring of bleeding or leakage of bile. Abdominal collection, biliomas, or subhepatic abscesses are reported less with the placement of drains. Intraoperative detection of bile duct injury is commonly noticed with open than laparoscopic cholecystectomy. Laparoscopic injury is attributed primarily because of inexperience with instrumentation and techniques, or the experienced surgeon familiar with the proper method yet with inadequate exposure in the operative visual field due to acute or chronic inflammations. Next slide, please. Preoperative cholangiogram or preoperative ultrasonography of biliary tree is required to know the abnormal duct anomalies. In cases of severe inflammation and adhesions, Fundus' method was carried out least duct injury. Drain amount usually becomes nil by 6 post-op day. Cases in which continue to drain after 5 to 7 days approximate should be suspected as having duct injury and subject to ERCPs. Most of the post-operative bile leaks are managed conservatively and by endoscopic procedure, rarely require re-explorations. Now, mortality and morbidity with laparoscopic is much less compared to open cholecystectomy, provided it is done in experienced hands only. Next slide. These are my references. Thank you. Hello. Hello. Am I audible? Hello.
Hello.
Am I audible to everyone?
Yes.
Hello. Hello.
Yes, sir. Yes, sir.
Okay. In yours, Dr.
Dhruvesh. Yes.
Dhruvesh. In your
Yes.
study, the complication was more in open surgery than laparoscopic surgery of bile duct injury.
Yes, sir. Because there are chances
how do you
of
explain that?
conversion. Yes, sir. There are chances of conversion of laparoscopic to open surgeries in cases of chronic cholecystitis. That's why.
Okay, so you have included the converted surgeries
Yes,
also.
sir. Yes, sir.
Okay.
I have included that.
Okay, fine. Thank you.
Yes, sir. Thanks, sir.
Thank you, Dr. Dhruvesh. Next is Dr. Divya Patel.
Hello, am I audible?
Yes.
Good afternoon, sir. I'm Dr. Divya Patel, second year general surgery resident from SUP Hospital. I am presenting a case of clinico-pathological study of Cox abdomen under guidance of Dr. Archana D. Dalal ma'am, Kaushal D. Suthar sir, and Mayur Rabari sir. Next slide. Next slide. Abdominal tuberculosis is one of the commonest type of extrapulmonary tuberculosis. Abdominal tuberculosis denotes tuberculosis of gastrointestinal tract, peritoneum, lymph node, solid organs like spleen, liver, and pancreas. The incidence of abdominal tuberculosis is increasing due to increasing incidence of AIDS. It may mimic other gastrointestinal lesions like inflammatory bowel disease and malignancies. Abdominal tuberculosis continues to be the major cause of morbidity and mortality in India. Next. Aim and objectives are to study the clinical presentation and site of distribution of abdominal Cox, to study the incidence of abdominal TB presenting as acute emergency, and to study the management protocols of abdominal Cox. Next. This is a prospective observational study which includes patients diagnosed with abdominal Cox at a tertiary care teaching hospital in Ahmedabad over the period of January 2019 to July 2020. Total 50 patients were included in the study, pooled from OPD and emergency department. Data collected were analyzed, including age, sex, history, and clinical examination findings, and few Hematological investigations like hemoglobin, total leukocyte count, platelet count, RFT, LFT, prothrombin time, and electrolytes were collected, and few radiological investigations like chest X-ray, abdominal X-ray, CT scans were performed, and colonoscopy was performed in some cases as required. Tissue diagnosis was obtained by USG, CT-guided FNSC, true-cut biopsy, or excision biopsy of operated specimens by HP examination. Raised ADA levels or positive AFB staining of ascitic fluid was also considered positive for abdominal COX. All the patients were appropriately treated and followed up over the period of 6 months. Exclusion criteria are patients with age less than 13 years and pregnant females. Next. Observation and discussion. Table 1 is showing age distribution, in which present study approximately 55% of patients are younger than 30 years, with maximum number of patients in 21 to 30 years age group, and average age of the patient is 30 years. Next. This is a chart showing age distribution. Next. Sex distribution. In our study, male to female ratio is 0.85% with slight female preponderance. Addison and colleague reported high incidence in male, and M. Ismail and colleagues reported equal incidence in both male and female. And this is a pie chart showing sex distribution amongst abdominal tuberculosis patients. Next. Clinical presentation. Patient presents with various symptoms, being most common abdominal pain, followed by vomiting, abdominal distension, fever, diarrhea, constipation, weight loss, loss of appetite, and abdominal lump. In present study, the most common symptom is abdominal pain, which is comparable to the results of Das P. Shukla and colleagues and Bansali and colleagues. Next. This is a bar chart showing showing a clinical presentation in various group of patients. Sites of abdominal tuberculosis. Ileocecal region is the most commonly affected region, similar to the reports of Chalia and colleagues 2013, followed by ileum, mesenteric lymphadenitis, and peritoneal tuberculosis. Associated pulmonary tuberculosis was found in 13 out of 50 patients in present study. Next. This is a chart showing sites of abdominal tuberculosis in patients. Next. Investigations. Chest X-ray PA view was taken in all patients. About 13 patients showed evidence of pulmonary tuberculosis. Plain X-ray abdomen erect in emergency condition showed multiple air fluid levels in 9 patients and free air under diaphragm in 6 patients. ESR was done in 30 patients and was elevated in 18 patients, indicating ongoing inflammation. Montauk's test was performed in 10 patients and came strongly positive in 7 patients. Ultrasonography was done in all patients and showed presence of ascites, lymphadenopathy, dilated bowel loops, bowel thickening, pseudokidney lesions, etc. CT abdomen. 35 patients undergoing CT scan of the abdomen showed signs of lymphadenopathy, irregular soft tissue density, ascites, bowel wall thickening, pseudokidney lesions, and stricture. Those who undergone colonoscopy presented with symptoms of abdominal lump, altered bowel habits, and biopsies taken from ileocecal lesion confirmed the tuberculosis. Next. Next. Complications. Complications of abdominal tuberculosis are adhesions, obstruction, stricture, perforation, and intra-abdominal abscess. Intestinal obstruction is the most common complication. In present study, 11 patients presented with obstruction, 6 patients with perforation, 4 patients with stricture, and 2 patients with intra-abdominal abscess. Next. Next. Treatment. Emergency. Surgical treatment was offered to those patients presented with obstruction and perforation. 15 patients underwent emergency surgery. Emergency surgery for intestinal obstruction was performed in 9 patients, of which resection and anastomosis was performed in 2 patients. Adhesiolysis was done in 5 cases. Resection and ileostomy was performed in 1 case, and right hemicolectomy was done in 1 case. Emergency surgery for perforation was performed in 6 cases. All had ileal perforation, and of which 3 patients underwent primary closure and biopsy, 2 patients underwent resection and anastomosis, and 1 patient underwent resection and ileostomosis. Next.
2 minutes left.
This is a graph showing patients presented with obstruction and presented with perforation and the procedure done amongst them. Next. Elective surgery. Elective surgery was performed in 6 patients, of which 4 patients underwent resection and anastomosis and 2 patients underwent arteriolysis. 2 patients of intra-abdominal abscess were managed with laparotomy and drainage of abscess with broad-spectrum antibiotic coverage. Next. Result. Post-operative complication. 7 out of 21 patients presented with early post-operative complications like anastomotic leak, burst abdomen, SSI, septicemia among operated for emergency surgery. Next. This is a pie chart showing early post-operative complication, which shows 60% of patients showed no complication, 20% patient had surgical site infection, 6% with burst abdomen, 7% with leak, and 7% with septicemia. Next. After 21 patients operated for complication of abdominal TB, 2 patients died between 10 to 15 post-operative days, and 15 out of 50 patients presented with late complication like malnutrition, who eventually recovered with nutritional management and anti-tuberculous drug therapy. Next. Anti-tubercular drugs. All the patients were kept on anti-tuberculous therapy. Anti-tubercular treatment is still the mainstay of treatment, and all patients were given anti-tubercular treatment for 6 to 9 months. In short course chemotherapy, a daily 6 months regimen of HRZE for 2 months and followed by HRE for 4 months were given, and studies concluded that short course chemotherapy is as effective as standard regimen, and streptomycin, a second-line drug used in abdominal tuberculosis and MDR cases, was given in the dose of 0.75 milligram intramuscularly daily and 5 days a week during intensive phase in the first 2 months of treatment. Next. Conclusion. GI-TB is still one of the commonest abdominal ailment in India with varied presentation affecting relatively young age group. It constitutes a major chunk of abdominal emergency surgeries. Ileocecal region is the commonest site being affected by the tuberculosis. Post-operative complications are common in abdominal TB. Meticulous surgical techniques, intensive post-operative management, and good nutrition are cornerstone for managing the complications. Next. These are the references. Thank you.
Dr. Divya?
Yes, sir.
How many patients of this required a complete course of how much follow-up you have? Like the patients which get the how much follow-up of the patients you have?
Follow-up for 6 months, sir.
6 months, and you gave anti-tuberculosis treatment for how many months?
For 6 months.
6 months. How do you know that whether these patients were requiring further treatment or not? Like some patients may relapse after 1 year or 2 years also.
Yes, sir. 40% patient relapsed, and so they were requiring more months of treatment, as some required 9 to 12 months of treatment.
Okay, thank you.
Yes.
Thank you, Dr. Divya. Next we have
Khevna, can we hold for 2-3 minutes? I do need to attend one call.
Yes, sir, sure.
Thank you.
All the delegates are requested to keep their video on while presenting. Thank you.
दोनों पार्टी करते हैं।
Yeah, now next.
Okay.
Next. Next. Patient who sustained back. Yeah, patients who sustain head trauma are often assessed clinically using Glasgow Coma Scale. The GCS score provides a shorthand assessment of patients' neurological functioning. The GCS focuses on importance of central nervous system function and consists of verbal, motor, and eye-opening responses. A CT scan is probably recommended for all patients with mild head injury because certain patients with mild head injury who present with no or minimal disturbance subsequently deteriorates. Incidence of this phenomena, often referred to as talk and deteriorate, has been reported between 1 to 3%, and only 1% of all cases require neurosurgical intervention. Significant CT scan findings include midline shift of more than 5 mm, EDH, SDH, SAH, interventricular hemorrhage, hemorrhagic contusion, diffuse cerebral edema, depressed fracture, brain herniation, diffuse cerebral edema, and etc. This study aims to correlate clinically clinical assessment using Glasgow Coma Scale and CT scan finding in patients of traumatic brain injury. Next, method and materials. A prospective observational study was conducted at Tertiary Care Hospital, Ahmedabad. All the patients with history of head injury by any means were evaluated clinically, taking into consideration history, general examination, Glasgow Coma Scale, and CT brain finding who presented in emergency trauma from 1st February 2020 to 10th March 2020. Exclusion criteria. All the patients less than 12 years of age, all patients who were known case of hypertension, bleeding disorder, and diabetes, patients receiving anticoagulant drug, and those with history of previous cerebral vascular accident. Next. Detailed history of all patients followed by general examination and detailed examination of CNS was done. Injuries involving the other system of the body was also noted. After initial resuscitation, several craniocerebral trauma was graded with the help of GCS score. The table 1 shows GCS grading and the severity, mild, moderate, and severe. Next. All the patients included in the study, irrespective of GCS score, were subject to cranial CT scan with the intravenous administration of contrast. Patient in dorsal decubitus position, axial section were performed parallel to the infraorbital line with 5 mm thick slices in the region of posterior fossa and 10 mm at other areas of the skull. Data were analyzed by SPSS version 17. The correlation between CT scan finding and Glasgow Coma Scale was evaluated using chi-square test. P-value less than 0.05 was considered significant. Next. Result. Total 108 patients with head injury were enrolled in the study done at the Tertiary Care Hospital, Ahmedabad. In present study, as shown in the chart 1, males while female were 34, resulting male to female ratio of 1.9:1. Average age of patient was 31.17 years. This is the chart of sex distribution. Next. In our study, the most common mode of injury was road traffic accident in 53% cases, followed by falls from the height in 29%, physical assault in 14%, and pedestrian in 4%. I have depicted it in the chart form. In our study, according to the Glasgow Coma Scale, 101 had mild injury, 3 had moderate injury, while 4 had severe injury. In our study, 33% had significant CT scan finding. In significant CT scan finding, 17 patients had fracture, 15 patients had SH, 9 patients had EDH, 4 patients had SDH. Next.
This is the chart form of significant CT scan finding, in which we can see the fracture is the most common found, that is in 46%. Among the patient, significant CT scan finding were found in 30 patients with mild GCS. In our study, 101 had mild brain injury on GCS, out of which 94 patients had GCS score of 15. And among them, 24 patients had positive CT scan finding. P-value was calculated using chi-square 0.05.
2 minutes left.
Next. This is the correlation part. Next. Discussion. So in our study, as 108 patients were evaluated, there were 66% male and 34% female. Similarly, in Gupta Prasad study, there were 80% male and 20% female. Violence. In general, the number of male with access to automobile is higher than the number of women, and more men work away from the home than women, thus being more exposed to the risk condition. Next. Next. Okay. In our study, the most common word was RTA. Similarly, in Flabina, the most common words were previous. Similarly, Fabina, RTA was the most common mode, and in say also that RTA was the most common mode. And in our study, 36 out of 108 patients had a significant CT scan finding. Next. Similar results were found in so fracture
Time's
was the
up.
most common.
Please wrap up.
Go conclusion next. Next. Most commonly involved with road traffic accident being the most common etiology. Most common finding in CT brain was fracture followed by SAH. CT scan is essentially measurement of patient with GCS 15 as positive CT scan finding has been found in 25.5% cases, which will guide a more vigilant and better management of patient. Patient with GCS score 8 or less than 8 has been associated with one or more significant CT scan finding. Because of disagreement between the intracranial injury assessed by GCS score and CT scan of brain, the use of GCS score only for assessing the level of injury may not be sufficient, and therefore considering CT finding as the gold standard until a more reliable blood test or clinical test are available that aid in the early diagnosis and management of the same. Okay, done.
Hello, Dr. Fenil.
Yes, sir.
Hello. Yes. How
Yes, sir.
frequently did you measure the GCS?
On admission and after the patient came from the CT scan. So twice, and after any procedure, if any
Okay.
neurosurgical procedure was.
And what is the what is the delay in the CT scan?
No, sir. Because actually all the patients were CT scan is a वैसे in all head trauma injury, patient was directly taken to CT scan, so there was not a delay and not a for CT scan after CT GCS.
Okay. Okay. Thank you.
Thank you, sir.
Thank you, Dr. Fennel. Everyone presenting is requested to please check their internet connections before they start presenting. Next is Dr. Harsh Varia.
Am I audible?
Yes.
Myself, Dr. Harsh B. Vaidya, second year resident doctor, General Surgery Department, NHL Medical College. I am presenting a paper titled as a Clinico-Radiological Preoperative Predictors for Difficult Laparoscopic Cholecystectomy under guidance of Dr. Arshana Dalal, Dr. Kaushal D. Suthar, Dr. Mayur G. Rabari. Next slide. Next slide. Introduction. Cholecystectomy was considered the surgical procedure for gallstone disease in 1882 when its pioneer Carl Johann August Langenbuch performed the first cholecystectomy in a patient who suffered from cholelithiasis. Moret introduced laparoscopic cholecystectomy in 1987. LC is considered the gold standard treatment for most of the gallbladder disease. The advantage of the LC are earlier return of bowel function, less post-operative pain, cosmesis, shorter duration of hospital stay, and also earlier return to full activity. Next slide. What is the term difficult cholecystectomy? This refers to the multiple technical intraoperative difficulty that increases the risk for complication and significantly prolong the operative time. Subsequently, the surgical time and the cost increases. These include acute cholecystitis, empyema of gallbladder, gangrenous cholecystitis, porcelain gallbladder, and intrahepatic gallbladder, pyocele, and mucosal. Some of the reasons are, the first is elderly patients are more likely to have a difficult LC. Female undergo this surgery more frequently, but male tends to have a higher number of difficult cases. Recurrent cholecystitis is a predictor. Obese patients and those with recurrent cholecystitis tend to have a more difficulties. Previous surgery predisposed toward difficulties. And patients who needed preoperative ERCP had more chances of having difficult cholecystectomy. In our study, the checklist helped us symmetrically record all the relevant clinical factors and sonographic information and to convey it to the leading surgeon. The purpose to undertake this study was to evaluate preoperative clinical and ultrasonographic findings in order to predict the difficult cholecystectomy. This would be beneficial in terms of better management of the patient. Next slide, please. Methods and material. Previous slide. This next slide. Methods and material. The place of study, Department of General Surgery, SVP Hospital. Period of study, 10 months, May 2019 to February 2020. Patients, sample says all the patients who were admitted underwent laparoscopic cholecystectomy for cholelithiasis are included in these studies. Approximately 50 patients, 20 patients has a ultrasound finding along with cholelithiasis, and remaining 30 patients are only cholelithiasis with no other findings. Inclusion criteria. Inclusion criteria include symptomatic cholelithiasis, empyema gallbladder, mucosal, gallbladder polyp, and biliary pancreatitis. Next slide. Exclusion criteria. Patient with CBD calculi, dilated CBD, raised alkaline phosphatase, where the CBD exploration was needed in this case were excluded, and requirement of preoperative ERCP. The patient who refused surgery, that is laparoscopic cholecystectomy. The patient with any sign and symptoms of obstructive jaundice. Patient who are not fit for laparoscopic cholecystectomy. The patient below 18 years and below above 60 years are excluded. Absolute contraindications like cardiovascular, pulmonary disease, coagulopathies, and end-stage liver disease were excluded. The laparoscopic cholecystectomy performed with other laparoscopic intervention in the same settings. Study variables, ultrasonographic prediction included GB wall thickness more than 4 mm, predict the difficult laparoscopic cholecystectomy. Gallstone mobility, impacted gallstone at the neck of the GB is taken for difficult cholecystectomy. Gallbladder size or gallbladder content like contracted GB, therefore predict the difficult cholecystectomy. CBD diameter, and last one is the number of calculus, single or multiple calculi. Next. Operative criteria, more than 90 minutes taken from laparoscopic cholecystectomy from insertion of the trocar until extraction of GB was considered difficult. More than 20 minutes to dissect Calot's triangle were considered difficult. More than 20 minutes taken to dissect the GB from the GB was considered difficult. Any laparoscopic which include total score grading, easy less than 5, the time taken less than 60 minutes, no bile spillage, no injury to duct or artery. Difficult 60 to 10. Time taken 60 to 120 minutes, bile and stone spillage. Injury to duct, no conversion. And very difficult, 11 to 15. Time taken more than 120 minutes, conversion. Next. These are the variables which are used for preoperative scoring, like age, sex, history of hospitalization, BMI, abdominal scar, palpable GB, GB wall thickness, less than 4 mm or more than 4 mm, pericholecystic collection, and impacted stones. Results. The study included the total patient of the age ranging from 18 to 17 years, in which 30% was seen between the age of 40 to 49 years, 67% are male, and the 33%, 67% are female, and 33% are male. Next slide. These are the predictive association between risk factor and the intraoperative outcomes. The first predictors are clinical predictors. In the age group, we can see the most of the patients are between the age group 41 to 50 years. In gender, it is male gender are more susceptible for difficult cholecystectomy. For acute cholecystitis, 40% of the patients were difficult cholecystectomy. In previous abdominal surgeries, 60% of the patients have difficult cholecystectomy. Next slide. The patient who had ERCP with stenting had 83% chances for difficult cholecystectomy. BMI more than 25 had 60% chances for difficult cholecystectomy. Tenderness in RHC also lead to difficult cholecystectomy. Palpable GB, 80% chances are there. In sonological predictors, contracted GB, because contracted GB, we cannot hold GB during laparoscopic cholecystectomy. In distended GB, 60% chances. In inflamed GB, 75% chances. For impacted stone, 66.6% chances for difficult cholecystectomy. For GB wall thickness more than 4 mm, 30% chances for difficult cholecystectomy. And in pericholecystic collection, there is not significant. Next.
2 minutes left.
Next. Next. In the operative timing to GB extraction, more than 90 minutes with the patient gallstone with other findings have a 45% chances. For dissection of GB from the GB bed, more than 20 minutes, 20% of the patient have a gallstone with other findings. In the dissection of the callots, more than 20 minutes, in 15% of the patient have a gallstone with other findings. Next slide. Lifestyle as a predictor. Sedentary lifestyle has more percentage of for difficult cholecystectomy. Next. Next. Conclusion. Laparoscopic cholecystectomy has established itself as one of the most safest procedure. Laparoscopic LC is minimal invasive surgery. What will look simple might not be simple all the time, and in the case, some consequences can be devastating. Hence, there need to be a way in which difficult could be anticipated pre-operatively. The following conclusions are: surgeon encounter difficult when there are dense adhesion in the callus triangle, fibrotic contracted GB, actively inflamed GB, gangrenous GB, cholecystoenteric fistulas. Parameters, namely the male sex, previous episode of cholecystitis, previous upper abdominal surgeries, sonography, in sonological finding, thick gallbladder wall more than 4 mm, age more than 50 years, preoperative diagnosis of acute cholecystitis were found to have a significant effect on the risk of conversion and statistical analysis. The technique has been standardized, and complication rate in conversion to open surgery are almost rare in the expert hands. And LC is now considered the entry-level surgery for the beginners in the laparoscopy. With increasing awareness and trend of the litigation, it is responsibility of the surgeon to explain all the possible outcome post-surgery. Even more so, if the surgery is difficult, no time can be better than the patient first visit to outdoor, and conversion becomes more convincing if we predict the difficult LC. Better planning help can save both the time and currency, establish a better patient-surgeon relationship in terms of complications or in case of conversion to open surgery. This study combined the pre-operative clinical and radiological parameters for the better prediction of the difficult LC. Thus, provide a basis for the further study to validate in aspect and also aids in formulating the efficient scoring system for prediction for difficult LC and reducing the incidence of complications. Next. Next. These are references. Thank you.
Okay, Dr. Harsh.
Yes, sir.
What is the significance of pericholecystic fluid in differentiating the predictor?
Polycystic collection is found in the patient of acute cholecystitis, which may signify the inflammation, ongoing inflammation, which may lead to obscure anatomy. So there was a difficulty in cholecystectomy.
So, okay, and how many percentage?
Sorry, sir.
Hello.
Hello.
Okay, thank you.
Okay, thank you.
Thank you, Dr. Harsh. Next presenting is Dr. Janki Panchal.
Yes. Am I audible?
Yes.
Good afternoon, sir. My presentation is on a study of etiology, risk factor, clinical presentation, and early post-operative complications of 50 cases of incisional hernia. Next. Introduction. Incisional hernia is a diffuse extrusion of peritoneal and abdominal content through a weak scar of an operation or accidental wound. Incisional hernia are most common complication of abdominal surgery with an estimated incidence of 2 to 11% after abdominal operation. Postulated predisposing factor for incisional hernia are obesity, diabetes, steroids, smoking, old age, malnutrition, multiple laparotomies, COPD, type of incision and closure, including suture material used in previous surgeries, and most importantly, the wound infection. Next. Aim of this my study is to evaluate the patient having incisional hernia with respect to age, sex, site of swelling, and incision, previous surgery done, clinical presentation, early post-operative complication like hematoma, seroma, wound infection, and early recurrence. Next. Methodology. This is a retrospective observational study conducted in my hospital, which consisted of 50 patients of incisional hernia who underwent open mesh repair using Prolene mesh as standard management protocol. Inclusion criteria: all patients with incisional hernia having age more than or equal to 18 years or less than 70 years, irrespective of sex. Patient who followed up for 1 month. Exclusion criteria is patient having associated inguinal hernia. Next. Patient having complicated hernias or patient who are medically or anesthetically unfit. Data is collected regarding demographic profile, clinical history including past operative history, associated risk factor, clinical presentation, physical examination finding, operative technique, and post-operative complication. Post-operative pain is assessed using visual analog categorical scale. Next. A result, out of 50 patients of incisional hernia, 40 were female and 10 were male. Average age of presentation is 47.5 years, with 66% being more than or equal to 45 years, and 34 is less than 45 years. Duration between onset of swelling and previous surgery, 46% of patients are presented within 1 year of previous surgeries. Next. Type of incision of previous surgery. Out of 50 patients examined, 35 has midline incision, 1 had pyramidal, and 14 had transverse incision. Type of surgery done, out of 35, 25 has explanatory laparotomy done, 8 had hysterectomy, and 2 had tubal ligation. Out of 14 transverse incision, 10 were of LSCS and 4 were of stoma closure. Next. 30 out of 50 patients, 30 has emergency surgeries and 20 were planned surgeries. In respective evaluation, 24 patients were found obese, 6% had chronic cough, and 4 were smoker. 8 had history of constipation, and 3 had history of micturition difficulties. Next. Clinical presentation. All present in a study are presented with swelling in the abdomen, and 26% also had pain in the swelling. On examination, the most common site will be was the infraumbilical region, 48%, and next will be umbilical and supraumbilical region. Operative technique, all the patient in my study was operated by open preperitoneal retrorectus incisional hernioplasty as a standard management protocol. Next. Post-operative complication. Wound infection is seen in 14 cases, seroma in 3, and early recurrence in 1 cases. Wound infection and seroma, all patients are managed conservatively. Post-operative pain, in immediate post-operative period, all the patient had moderate to severe pain, which was decreased in 14 days, with 44 patient has no pain and 6 has mild pain. Next. Relation of post-operative complication and risk factors. So out of 14 patient having wound infection, 10 had obesity as associated risk factor. Similarly, 3 cases of seroma, 2 had obesity as a risk factor. Next. A discussion. In my study, there is 46% patient developed hernia in within 1 year of surgeries. Similarly, study showing result that 54.4% had a incision hernia in 1 year of surgery. 70% in my study had a history of midline incision. 28 had transverse and 2 had paramedial incision. So similar study showing midline incision having a higher rate of hernia, incision hernia, as compared to transverse or paramedial incision. In my study, 48% were found obese. In a similar study, it is shown that increasing chances of acquiring non-inguinal hernias with obesity, which is significantly related to the acquisition of hernia. Next. 8% in my study, 8% were giving history of smoking. A similar study shows that smoker had fold-fold rise of increased incisional hernia rate. 58% of incisional hernia occurred in infraumbilical region. A similar study showing that there is increased chances of incisional hernia in infraumbilical region. This is because of higher hydrostatic pressure in the lower abdominal compartment in a standing position. And next. Deficient posterior rectus sheath below the arcular line. In my study, there is 28% patient had a wound infection and 6% had seroma. Similar with as compared to similar study, my study had higher rate of postoperative wound infection, but comparable rate of seroma. Immediate postoperative period, 33% patient had a moderate pain and 17 had severe pain, which was decreased subsequently with as day passes.
2 minutes left.
Conclusion: midline vertical incision carried higher risk of developing incisional hernia. Most incisional hernia developed within 1 year of surgery. Wound infection, in my case, is 28% of operated patient, and it is the commonest risk factor for it was found obesity. So meticulous aseptic technique and careful closure of abdominal wound is necessary to prevent the incisional hernia. Okay, thank you.
Okay, Dr. Janki.
Yes, sir.
What was your experience with the different kind of meshes?
Sir, in this study, there is a soft polypropylene mesh was used in all 50 cases. So, sir, that was not studied.
Hello.
Hello.
What are the characteristics of this mesh?
So it is made up of soft mesh, which is made up of polypropylene, that is proline, and
okay, thank you. Thank you.
Thank you, Dr. Janki. Next presenting is Dr. Jaideep Maheshwari.
Hello.
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 Dr. Jaideep.
Am I audible?
Yes.
Yes. Good afternoon, everyone. Good afternoon, sir. I am Dr. Jaideep Maheshwari, second year surgery resident at Srimati NHL Municipal Medical College. and I'm going to present on a retrospective study of management and clinical outcome of 30 patients presenting with ventral hernia under the guidance of Dr. Kirti Parmar sir, Dr. Pratik Vyas sir, and Dr. Varun sir. Next slide, please. The aims and objectives of my study are that to study the ventral hernias with respect to the various anatomical sites, various types, and their clinical presentation at different stages, to study the various risk factors and complications of different types of ventral hernias, and to study the various methods of using prosthetic materials like various type of mesh. Next slide, please. Introduction. Starting with the definition of the hernia. The hernia is defined as abnormal protrusion of the whole or a part of the viscus through the wall that contains it. And ventral hernia is defined as the hernias protruding out through the anterior abdominal wall. And the clinical history regarding the duration of hernia, progression in size, and associated complaints like pain, vomiting, reducibility was taken. Chronic cough, constipation, difficulty in micturition, abdominal distension, history suggestive of ascites and other causes of abdominal distension were evaluated. And in local examination, special attention was given to the position, size, shape, composition, cuff impulse, reducibility, and skin over the swelling, size of the defect, and position of the previously operated scar. Next. Among all the ventral hernia, incisional hernia, epigastric hernia, and umbilical hernia are common, and their incidences are as follows. Epigastric hernias are 7 to 8%. It constitutes 7 to 8% of all the ventral hernias, and they are most common in the women. And if seen in female, the risk factor for that is multiparity of the patient, and strangulation is very unusual. While in umbilical hernia, the chances umbilical hernia are more common in women and in obese patients, and strangulation is more common in women, and the incidence is more in 40 to 50 years of age, and they account only 0.03% of the total hernias. And incision hernias are the most common in, hernias presenting as the ventral hernias. According to Rodney Mengott, approximately 8% of the cases subject to abdominal operations developed incision hernia post-operatively. Next slide, please. This is the classification of the ventral hernia. Next slide. Materials and methods. 30 cases were studied in our department, and the patients were diagnosis of ventral hernia were admitted in the Department of General Surgery, and the patients were randomized to undergo the various surgical procedures depending on the age, presentation, tone of the abdominal muscle, and affordability of the patient for the operative procedures. All the patients were either treated with retrorectus meshplasty or retrorectus meshplasty with component separation technique or preperitoneal meshplasty. And retrorectus meshplasty with component separation was done in the patients presenting with size defect more than 10 cm or presenting with full thickness abdominal wall dehiscence. And the follow-up period was only of 3 months after the discharge of the patient. Next slide, please. The inclusion criteria includes the patient with ventral hernias admitted at surgery department in our institute, and the excluded patients were with the size defect less than 1.5 cm or operated with laparoscopic hernia repair. Next slide, please. These are my observations that among the 30 cases of the ventral hernia, 16 cases were of incisional hernia, while 3 cases were of epigastric, 8 cases were of umbilical hernia, and 3 cases were of paraumbilical hernia. The pie chart is showing the same. Next slide, please. The sex incidence is discussed here, and it is seen that ventral hernia is more common in females, that is 57%, and in males 43%. And in ventral hernias, incision hernias were more common, and that too in females, 10 cases presented out of 16 cases. And among epigastric hernia, all the cases were exclusively male. Next slide, please. Next slide. Now, age distribution of various ventral hernia. The younger patient with the ventral hernia was female of 30 years, and the oldest was of 68 years with paraumbilical hernia. The highest incidence of ventral hernia was noted in the fourth defect, that is 14 cases out of 30 cases were in the fourth decade, and the lowest incidence was noted in the sixth decade. Among the incisional hernia, most cases were found in the fifth decade, and among the umbilical hernia, all the cases were noted in the fourth decade. Next slide, please. This is the chart showing sex and age distribution. As we can see that in fifth to sixth decade, majority of the cases are there. Next slide, please. Clinical features. All the 30 cases of the ventral hernia presented with the swelling, that is 100% patients presented with swelling, while 34 of patients had pain, and irreducibility, obstruction, strangulation was seen in only 10% of cases, and they all and the patients of obstruction strangulation presented in the emergency, and among the incisional hernia, all the 16 presented with swelling. In case of epigastric hernia, no reducibility and no strangulation was seen, while in the cases of paraumbilical hernia, 3 cases were there, out of which 1 case presented with pain and irreducibility and obstruction. Next slide, please. This chart shows the clinical features of various hernias. Next slide, please. Now, predisposing factors of the ventral hernia. In my study, 50% of the cases had history of previous surgeries, while 40% of the cases were obese and 30% were multi-para, while 26.6% of cases had diabetes as comorbidity and 20% had chronic cough, seconding to chronic obstructive disease. Next slide, please. Now, the types of incision of previous surgery in case of incisional hernia. As in my study, out of 16 cases, 12 patients had midline incision, out of which 8% had vertical midline incision and 4 had vertical lower midline incision. 1 developed port side incision hernia, and that too in the case of laparoscopic appendectomy, and 3 had transverse incision. Next slide, please. Now, the management of the ventral hernia. All the patients were either treated with retrorectus mesh plasty or retrorectus mesh plasty in component separation technique or pre-peritoneal mesh plasty. In my study, out of 16 cases of the incisional hernia, 2 cases were presented with size defect more than 10 centimeters in size. So they were treated with retrorectus mesh plasty and component separation technique. And other 7 out of 16 cases were treated with retrorectus mesh plasty and 7 were treated with pre-peritoneal mesh plasty. Out of 8 patients of umbilical hernia, 50% of the cases were treated with retrorectus mesh plasty and 4 were treated with the pre-peritoneal mesh plasty. And in epigastric hernia, all the patients were treated with retrorectus mesh plasty. And in umbilical hernia, paraumbilical hernia, 2 of the cases were treated with retrorectus mesh plasty and 1 case was operated with pre-peritoneal mesh plasty. Next slide, please. This is the chart showing various surgeries. Next. Complications of the ventral hernia. The most common complication of the ventral hernia repair was seroma, which was seen in the 20% of the patient, which was followed by the infection, which was seen in 13.33 patients. And paralytic ileus and obstruction was observed in 1 patient, which was managed conservatively. As the follow-up period was very short of 3 months, the recurrence rate cannot be commented. Next, please. And in cases of incisional hernia, in 10 cases, a drain was placed above the mesh, and in 6 cases, 2 drains were placed, one above the mesh and other in the subcutaneous tissue according to the subcutaneous tissue volume of the patient. Mainly in the obese patient, subcutaneous mesh drain was placed, and out of the 8 cases of the umbilical hernia, drain was placed above the mesh in 2 cases, and in 6 cases, no drain were placed. In a paraumbilical and epigastric hernia, no drain was placed. And the average stay in the hospital was of 6 to 8 days, and the removal of the drain was done on the first postoperative day on an average. And patient having diabetes had longer duration of stay, that to 8 to 9 days, and suture removal was done on 11th postoperative day on an average. Next slide, please.
Time's up. Please wrap up.
Conclusion. This is a retrospective study of the management and clinical outcome of the patient presenting with ventral hernia. In our study, there is a female preponderance for ventral hernia. The maximum incidence was noted in the 4th decade, and the commonest presenting complaint was a swelling in the anterior abdominal wall. And the commonest ventral hernia is incisional hernia, and irreducibility was noted in 10% of all the ventral hernias. Previous surgery was the commonest precipitating factor for all the ventral hernias, and incisional hernia was found to occur more in females compared to males. And incisional hernia were found commonly in the midline, in the lower, and in the infraumbilical incision. In our study, retrorectus mesh plasty proved to be better in terms of less complexity in the technique, less postoperative pain due to minimal tissue handling, and less postoperative complication than pre-peritoneal mesh plasty. Next slide, please. However, difference between the recurrence rate of the 2 techniques cannot be commented as because of the smaller sample of a study, and the follow-up period was of just 90 days, whereas 50% recurrence rate can be expected. However, more appropriate period of follow-up should be 1 year, which could not be carried out in a study. Thank you.
Okay, Dr. Jaydeep,
Yes, sir.
what do you think about obesity as a factor?
Sir, obesity as such it increases the chances of the ventral hernias, and it is a uniform risk factor for developing of ventral hernias. And while operating in obese patient, there is more operative time, as well as the subcutaneous tissue is handled for longer duration of time. So drain is kept in the subcutaneous tissue in obese patient.
Good morning, sir. તું અંદર બેસ પેલા મેં કેવડાવ્યું છે. Okay, thank you, Dr. Jaydeep.
Thank you, sir.
Thank you, Dr. Jaideep. Next presenting is Dr. Karan Sharma.
Yeah, am I audible?
Yes.
Hello everyone, I am Karan Sharma. I am a final year MBBS student. Hello?
Yes, please continue.
Yeah, I am a final year MBBS student and I am going to present my case report on cystobiliary communication of hydrated cyst. Next. These are the aims and objectives of my presentation. Next. So communication of bile duct with hydrated cyst can be small, or it can be it can also lead to frank intrabiliary rupture, and it may be asymptomatic or may cause obstruction of biliary system, resulting in obstructive jaundice and sometimes cholangitis. Next. The causative organism is Echinococcus granulosus, and the mode of transmission is hand to mouth from fur of definitive hosts such as dog or cat, contaminated dirt such as dog feces, and fecal contamination of food and water. Next. The patient was 28-year-old male who was working as a farmer in nearby village, and he visited our surgical OPD, and he had the complaint of abdominal pain since 1 month, on and off fever since 1 month, and feeling of nausea, anorexia, and vomiting since 20 days. Next. The patient was relatively asymptomatic before 1 month. He developed acute abdominal pain, which initially subsided with painkillers. Later, the pain was postprandial, and he also began experiencing on and off fever since 1 month. Uh, he, he also experienced occasional episodes of nausea, anorexia, and vomiting. He consulted local clinic in his village 10 days ago and was treated with antispasmodics and antiemetics. And upon not getting any improvement despite taking medicines, he has visited GCS hospital. Next. On physical examination, we noticed that the patient had Karnofsky score of 80. He had slight fever, icterus, and right hypochondrium pain. Next. Laboratory investigations showed that SGPT and direct bilirubin were elevated. Next. So radiology was done to determine the location, size, and extent of the pathological lesion. Next. USG abdomen showed two well-defined anoic cystic lesions with calcified wall in segments 6 and 7 of right lobe of liver. There was distended gallbladder and prominent CBD. Next. X-ray abdomen showed well-defined calcified lesions in right hypochondria. Next. CT abdomen showed well-defined calcified hypodense lesion in segment 7 of right lobe of lobe communicating with segment corresponding to right hepatic duct. Next. So the diagnostic was made of communicating calcified hydrated cyst with corresponding hepatic duct leading to CBD blockage. Next. The therapeutic options usually depend on the size of the cyst, location of the cyst, proximity to the vessels, and experience of the surgeon. Next. The pharmacological treatment of antihelminthic albendazole was given. The pain management was done by buscopan, and antiemetics were given when needed. Next. Surgical management in case of frank intraocular rupture is a very hotly debated topic. In our patient, we manage it conservatively. Endoscopic retrograde cholangiopancreatography (ERCP) was done for further diagnosis and management. ERCP showed narrowing of the distal CBD with communicating cyst, and a guided stent was inserted. And the reasons why we not opted for the radical treatment was because of the difficulty, low applicability, and high mortality of the patients. Next, the outcome was that the stent was removed after 2 weeks. No signs of jaundice were observed in the patient, and serum FGPT and bilirubin levels were normal. Next, discussion. Incidence of vestibular communication of hydrated cyst is 2 to 42% in different studies among patients with liver hydrated cyst. Communication can be honest, which means bile within the cyst, or insidious, which means absence of bile in the cyst. Usually, in frank intraocular rupture, the death of the parasite occurs due to destruction of germinal layer of the cyst by bile, which leads to calcification of cyst. Next, due to absence of internationally accepted definition, there is no standardized regimen or management of vestibular communication of hydrated cyst. As stated earlier, conservative management should be preferred in case of frank intraocular rupture rather than radical management. And goal of the treatment should be handling of the cystic cavity, cleaning of the bile duct, and restoration of the bile flow. Thank you.
Dr. Karan.
Yes, sir. I'm a student, final year MBBS student. I'm not a doctor yet.
Okay, okay. Nevertheless, tomorrow you will be. Uh, what, uh, uh, what, what is your view on Hello?
Yes, sir.
Yes. So, what are the treatment options available for cystobiliary communication, and what is the preferred method?
Sir, in case of where the communication is very small and there is very less risk of rupture, we can opt for the radical management. But in our case, there was a frank intraocular rupture, so that is why, and cyst was also calcified. So we opted for the ERCP management, where we just put the stent on the bile duct.
Okay, thank you.
Yeah. Thank you, sir.
Thank you. Next presenting is Dr. Kavan Takwani.
Hello. Am I audible?
Yes.
Okay. Good afternoon, everyone. I am Dr. Kavan Takwani, second year resident at Sri Krishna Hospital, Karamsad Medical College, Karamsad. I am presenting a comparative study on wet collagen tracing versus conventional silver sulfur tracing in partial thickness burns. Next. Burns injuries are extremely complex in their occurrence and pathophysiology. WHO defines burns as a destruction of some or all layers of the skin when they come in contact with hot liquids, hot solids, or a flame, electric current, lightning, or a radiation injury. Its optimal treatment requires holistic approach, understanding physiology and metabolic interactions among all the major organ systems, nutrition, immunology, and psychological issues. Problem faced the most during management of burn patients is wound management. Ideal management of burns is an economical, easy to apply, readily available dressing or method of coverage that will provide good pain relief, protect the wound from infection, promote healing, prevent heat and fluid loss, be elastic and non-antigenic, and adhere well to the wound. Also waiting for spontaneous epithelialization of the partial thickness burns. The conventional dressing of burns include wound cleaning followed by application of 1% silver sulfur. Next. SSD has become a drug of choice in burns tracing due to its broad spectrum action against gram-positive and gram-negative bacteria as well as fungi. But there are two main concerns. One is the systemic absorption of silver, which remains in the body even after dissociation. This absorption becomes significant in burns involving larger burn surface area. Second is conventional tracing is repeated daily or at least alternate day which are painful dressings, especially in pediatric population where frequently anesthetic services are needed for dressing change. Next. Collagen is an endogenous substance which forms an important structural component in connective tissue and is of special importance in the skin. The importance of collagen in healing has been appreciated for many years for the simple reason that the end result of wound healing is always a scar which is composed of collagenous fibers. Biological dressings with collagen create the most physiological interface between the wound surface and environment, which are impermeable to bacteria. Collagen dressings have other advantage over conventional dressing in terms of easy application and being natural, non-immunogenic, non-pyrogenic, hypoallergic, and pain-free. Next. The aims of this study is to compare effectiveness of collagen dressing in partial thickness burns over SSD, and also to compare the outcome of dressing in terms of infection, healing, pain score, resultant scar, patient compliance, and cost effectiveness. Next. I have included 60 patients in this study. In the span of 6 months presenting to Sri Krishna Hospital, collagen dressing was applied in 30 patients after taking their consent, and other 30 patients were treated with SSD dressing. Next. We have included partial thickness burns of grade 1 and 2 involving any percentage of the body surface area presenting on any post burns day in which burns wound is not infected and giving their consent. Next. Patients having full thickness burns who are vitally unstable or unsalvageable, patient having infected burns wound, electric or radiational burns, and burns over face and perineum were excluded. Next. All patients were assessed clinically as to percentage of the body surface area involvement, the degree of burns, and mode of treatment. The patients were followed up on a daily basis in both test and control groups until complete epithelialization occurred. The control group was subjected to alternate day dressing by conventional SSD dressing, whereas test group was subjected to collagen dressing and was left undisturbed until complete epithelialization occurred. Dressings were reapplied if any infection of collagen dressing occurred. Next. Collagen sheets, 1% silver sulfadiazine, and dressing with cotton pads and roller gauze were used. The collagen used in this study is a purified, reconstituted collagen. This reconstituted collagen is then cross-linked with tanning agents like glutaraldehyde or chromium sulfate to improve its tensile strength, to make it insoluble, to decrease its rates of reabsorption, and to lower its antigenicity. They are available in various sizes and thickness is 0.6 mm. It is sterilized by gamma irradiation. Next. This is the technique with which we have applied the SSD dressing and collagen dressing. Next. All patients were followed by the antibiotics and fluid resuscitation was given according to the Parkland formula. Patients were followed up in burns isolation ward and they were discharged once complete epithelialization occurred. Time taken for complete epithelialization in both the group was noted. Next. The variables analyzed were pain score, infection rate, rate of healing of the wound, resultant scar, patient compliance, and cost effectiveness. Next. In this study, a 10-point visual analog scoring system was used with 0 standing for no pain and 10 implying maximum pain. Scores were recorded in post burns day 2 and day 7. Next. The average pain score recorded in the collagen patients on post burns day 2 was 2.85, while in SSD dressing, it was 4.5. Next. Pain score on day 7 was 1.15 in collagen group and 3.66 in SSD group. The P score is less than 0.001, suggestive that there is significant decrease in the pain in the collagen group. Next. This is a 70-year-old male with superficial scald burns over the lower limb. Patient was in severe pain and after application of collagen on day 1, significant reduction in the pain was there. Next. Infection rate, which was considered as development of slough, eschar, necrosis, or pus over the burnt part. Infection was present in 6.7% of the patients in collagen group, while 46.8% in SSD group. In experimental group where collagen was applied, only one patient needed reapplication of collagen dressing due to infection. Next. Can you please play the video? You can go in the lower part of the video to play. Anyway, it's a 2-year-old female child with superficial scald burns involving 35 to 40% of the body surface area. On presentation, patient was in severe pain. After stabilization, collagen dressing was applied And on post months day 15, patient just had a small infection over the back, and after that it hypergranulated and healed as a keloid. This is a picture of post months day 180. The keloid was dealt by the dermatology department, and now patient is fine. Next. Rate of healing. Healing was considered over when more than 90% of the body surface area was epithelialized. Healing was achieved on an average of 13.57 days in collagen group and 25.7 days in SSD group. Next. This is an 18-month-old male child with superficial skull burn involving 45 to 50% of the body surface area. Collagen was done on presentation in the trauma only. On day 15, you can see in the picture, the wound was nearly completely healed. And this is the picture of post-burns day 365. The scar is cosmetically excellent and patient has no fresh complaints. Next.
2 minutes left.
Resultant scars were good, were analyzed by good if less than 50% of the involved area got contracture, and bad if more than 50% involved area got contracture. 100% of patients in group 1 and 77% in group 2 had good scars. Next. This is a video of a 19-year-old male with grade 2 flame burns involving 75 to 80% of the body surface area. On post burns day 60, with help of minimal physiotherapy, patient was all up and walking, doing all his day-to-day work and working at his job, and has no fresh complaints. Can you please play the video?
I think there is some issue with the video.
Anyway, next. Cost effectiveness. With p-value greater than 0.05, the cost effectiveness in our study was not statistically significantly analyzed, but the patients treated with silver sulfadiazine had to spend more due to prolonged hospital stay, more analgesic use, more antibiotic use, including loss of time and labor of both the patients and the person accompanying. Next. Next. So, to conclude, collagen provides an ideal dressing for partial thickness burns owing to its properties. Pain was significantly reduced in patients dressed with collagen since it forms a temporary barrier preventing any external source from stimulating nerve endings to cause pain. Collagen dressings help to form a mechanical barrier between wound and environment, thus preventing infections. The rate of wound healing was significantly faster in collagen dressing than SSD. This was due to the properties of collagen providing an optimum environment for early wound healing. The morbidity of patients too is less as the scar formation is healthy in most of the patients using collagen owing to its properties of inducing granulation and epithelialization. The collagen dressing is more cost effective than SSD. SSD has disadvantage of large number of dressings, prolonged hospital stay, amount of pain, loss of time and labor of the patient and the accompanying person, which makes collagen dressing much more cost effective and efficient as it is the most of the time a single dressing. So we can say that collagen dressing is helping to the burns patient, all starting from the pediatric age group to the elderly age group. Thank you.
Okay, doctor, is there any side effects or the complications for this collagen dressing in your study?
Sir, among the 30 patients in which we used the collagen, there was no adverse drug reaction found in any of the patients. Only one patient out of the 30 developed a small infection, which was dealt with keeping an incision over this collagen sheet. And then after that, removal of that collagen sheet, reapplication of a new collagen sheet. But no other reaction was found.
Okay, thank you.
Thank you, sir.
Thank you. Next presenting is Dr. Ketan Patel. Dr. Ketan Patel. Okay, we'll continue. Dr. Keyur?
Yes, I am there. Am I audible?
Yes, you are audible. Is this your presentation?
No, this is not. One minute. Yeah, this is mine.
Okay, we'll continue with you.
So, good afternoon, respected sir and all my dear friends. I am Dr. Keyur Ustadia, a third-year resident in General Surgery Department at GCS Hospital. I am going to present my research paper on vacuum-assisted closure of acute and chronic non-healing wounds and effective therapy done under the guidance of Dr. Ayush Jain and Dr. Sushil Agarwala at General Surgery Department, GCS Hospital. Next. Now, vacuum-assisted closure therapy, also known as negative pressure wound therapy, has brought a revolution in the wound management since last 15 years. It was introduced first by Fleischmann in 1933. Here, the basic principle is the removal of blood and serous collection from the wound with the help of a negative pressure. Here, with the help of a piece of foam and a drain, continuous negative pressure is applied to the wound of around -125 mmHg. Next. In the picture, we can see that there's a wound extending into the deeper tissues. There's a foam applied over the wound which covers the wound, and it is attached to the drain which is applied to the suction device. So with the help of the negative pressure, there's a continuous suction of the serous fluids and collection into the suction device. Next. Now, how does it work? Here, the interface material used in the VAC therapy stretches the cells at the base of the wound. This induces the rapid division and proliferation. Also, it creates an hypoxia, which is favorable for the angiogenesis. And it provides all the mechanisms that keep the wound warm, moist, and prevent the desiccation. Next. Now, main objectives of the therapy are to promote the rapid healing, to decrease the wound change frequency required, to prepare the faster granulation tissue bed so that the early further surgical intervention for the closure of the wound can be undergone, example split thickness grafting, and to promote the contraction of the wound edges. Next. Now, materials and method used for the study. We choose the study design prospective interventional. The research area was General Surgery Department of GCS Hospital. The study was conducted from 1st August 2019 to 31st January 2020. We included 30 patients as our study group. Next. Now, all the patients having chronic ulcers, non-healing ulcers, acute abdominal wound, abdominal open wounds, decloving injury, and pressure sores were considered as the cases were included in the study. We excluded patients with malignant wounds, untreated osteomyelitis, fistulas to the open body or other body cavities, and the patients below 18 years as well as those patients who were not willful to be a part of the study were excluded. Next. Now, sequence of procedures. First of all the dressing materials from the wound were removed. A culture swab stick was taken for the microbiological study. Now, depending upon the size of the wound, the surgical debridement was done either in the ward or in the operation theater. Hemostasis was achieved. After that, the clean sterile foam was selected and it was cut into the shape of the wound. It was applied gently over the wound, covering all the margins of the wound adequately. Next. Next, with the help of the plastic drape adhesive material, it was completely made airtight, covering around 3 to 5 centimeters of the normal margins of the skin. A drain was connected to it, and it was connected to the suction device. In this study, we use intermittent negative pressure of around -125 mmHg. We used 4 hours of active pressure and 30 minutes of pressure free. At night, we did not switch on the negative suction pressure for the pregnancy of the patient. Next.
Yeah, very good.
What are the things to check during the daily rounds while VEC therapy is being undergone? For the effective VEC therapy, it is necessary for the foam to remain crumpled. It shows that our wound is airtight. If there is failure of the foam to remain crumpled, we should go for the change of the dressing. Also, if there is any soakage, leakage, or failure of the foam to crumple, the dressing should be changed. In our study, we changed the dressing every 3 days. We should also observe for the color and quantity of the discharge into the suction device. Next. Analysis. In the study, we graded all the wounds using the wound scoring system, which was based on the area of the wound covered with the granulation tissue, its color and consistency. Now, the wound having no granulation tissue were given the score of 0, and the wound with complete granulation tissue were given the score of 4. Similarly, depending on the color and consistency, grading was given. Next. Now, in our study of 30 study individuals, 22 were male and 8 were female. Also, the patients were divided into 3 age groups, that is below 40 years, 41 to 50 years, and above 50 years. Maximum patient belong to greater than 50 years of age. Next. Now, the wound area and average wound score on each successive dressings. Here we taken the score of the every wound and assigned a mean average score to the wound depending on the area of the size. Now we change the dressing. We assign the score on day 0, that is on the application of the WEC dressing. On day 3, that is the first change of dressing. On day 7, that is the second change of dressing, and day 10, that is the third change of dressing. Now from this table, we can see that there is definitely increase in the average wound score from day 0 to day 10. This signifies that our results are that WEC therapy is doing good. The previous wounds which were not healing or either taking too long to healing are now showing signs of granulation and healing. Next.
2 minutes left.
Results, there is increase in the average wound score of the wound on the application of WEC therapy. There is decrease in the frequency of dressing change, and early split thickness grafting enables early closure of the wound and decrease in the hospital stay. Next. In the picture, we can see that the wound with dead necrotic tissues and slough, after the application of WEC therapy, there is complete granulation tissue over the wound, and after STG, there is closure of the wound. Next. Now, delayed wound healing is a significant health problem and challenging in the community, and particularly in the adults and with comorbidities. WEC therapy has been developed as an alternative to the standard wound management system. The use of the WEC therapy has proved a novel method for the manipulating the chronic wounds environment and to accelerate the wound healing. Next. Here the
Hello. Hello. Yeah, doctor, what is your experience with WEC dressing over abdomen?
The open abdominal wounds are we excluded the patient with enteroperitoneal fistula and all. The rest our experience was good, sir. The granulation tissue was faster as compared to the dressings without WEC.
Okay, thank you.
Thank you, Dr. Keur. Dr. Bansil Javia, is he present in the meeting? Dr. Faizan Syed? And Dr. Ketan Patel? Okay, so we have finished the presentation part for this session. Sir, would you like to say a few words before declaring the results?
Okay, I mean, I will be needing some time, maybe 15-20 minutes, because
Yes, you can text me the results.
Yes.
That's okay.
Yeah, because I need to compile the marking system which I had been devised for this. Okay, the presentation was good. Few of the students who could not, you should take care that you should try to complete it in allocated time, because paper when you are most of the presentations were taken as they are presenting in a publication. You see, when you are presenting a paper, it's a different than presenting in a publication. You should try to restrict yourself in your given time frame, that what is the important things you have to cover. You should do that, like rather than skipping 3 or 4 slides, you should try to cover everything. And many of times what was happening, that you were including unnecessary things, and a few important slides of discussion you had to omit. So this should not occur, right? Okay, so Kevna, I'll be needing maybe 15-20 minutes. I will send you a result in on WhatsApp.
Yes, sir.
Okay, thank you.
Thank you, sir. Thank you so much.
Thank you.
Thank you, delegates. We'll be informing you the results in a short while.
Thank you.
Thank you.
Thank you.